I'm Daniel Heller. I'm a board-certified pain management physician. Today we're giving a lecture on the treatment of pain. I'm going to talk about the different ways we can help you with your pain problem at Blue Ridge Orthopedic and Spine Center. The title of the lecture was Tame Your Pain, so I figured I Googled pain, or pain-free, I think, and she came up. So that's how my patients usually look after they've been through the pain management clinic. We rejuvenate them. It's pain management, and so it's for most of the chronic pain patients, we're not talking about curing pain, and a lot of what we do is learn how to manage pain and get patients more comfortable. Like Jeff said, I'm a board-certified pain medicine specialist or pain management specialist. I did my training at Northwestern University and then the Medical College of Virginia in Richmond, and I went to college in Michigan State University. Pain, you may not know, is the most frequent reason people visit the doctor's office, and even grouping common complaints together, you still get less visits for diabetes, cardiovascular disease, and cancer combined than for patients with chronic pain complaints. So it's important to have it, I think, as a medical specialty. It's a relatively new specialty. We've had certification for pain management as a ABMS recognized subspecialty now for about 5 years, I think, or maybe 10 years now. And so a lot of physicians aren't used to referring patients for these, refer for cardiology or for endocrinology or whatever, but there's oftentimes a pain management physician specialist in the community. When we see, as pain management specialists, when we see patients come in the office, we try to lump them up into different groups to figure out what we're going to do and how we're going to go about treating it. And for pain management physicians, a lot of what we do, about 90% of what we do, is chronic pain. And chronic pain is very different than dealing with acute pain problems. Acute pain obviously is meaningful and serves a purpose and important for your body to tell you, hey, the stove's hot, move your hand away from it and don't do it again. And so it gives you a little message and punishment there, so you'll remember to stay away from that hot stove. Chronic pain, it's not as clear why someone with knee arthritis or a back problem, why it has to hurt so much for so many years and it just won't go away. It's obviously not serving a very meaningful purpose, especially when you see the doctor, you have all the tests done, and you say, you know, your MRI doesn't look like that bad, your knee doesn't look that bad, I'm just not sure why it hurts so much. And certainly we see that quite a bit. And that's a chronic pain. And so chronic pain may be sometimes kind of a disease itself. It's the body just giving you a certain signal that's not necessarily meaningful. And when that signal becomes overwhelming, that's definitely something that needs to be evaluated if that's disabling to you. So when we lump, again, more lumping and splitting of these pain conditions, we're looking at operative versus non-operative care. Generally, for chronic pain, we're looking at more non-operative treatments, but there are a lot of chronic pain problems that are operable, and the same thing, there's a lot of acute pain problems that you don't want to operate on. But to the lumping and splitting of the chronic pain, you know, osteoarthritis, that's a chronic degenerative process, and when it becomes chronic at 3 months, but you obviously live with that for 30, 50, 60 years. So when osteoarthritis itself is a degenerative problem, but having knee pain from arthritis, that's not necessarily a disease. I'm talking about the pathology that comes with it. If it's disabling, even though the doctor says it's all right to walk on it. When it becomes all-encompassing to your life, that you can't work, you're getting depressed and sedentary, and all those things that come with chronic pain, that's the chronic pain disease part. Not, I have arthritis, therefore I have chronic pain disease, okay? This is another Google slide, and I thought it was really good. I was looking for pictures for the slide for operation, okay? But these guys are veterinarians. That's a small animal, but they looked like really into it, so I put it up. So we look for operative versus non-operative treatment. Generally, we're looking for conservative treatments first, but we do work in a multi-specialty group with surgeons, and we do refer when surgery is appropriate. why we do conservative treatments first, because surgery is never a 100% thing, period. No matter what the surgery is, it's not 100%, okay? So you can always try something and make sure that's the right idea. So like I said, we have a multi-specialty, multidisciplinary group. And what that means is if you come to Blue Ridge Orthopedic and Spine Center, you can see a surgical or non-surgical specialist that's trained, fellowship trained in their area of expertise. And we also have physical therapy in our office, a registered dietitian, a surgery center, and 6 surgeons. Certification is important and it does matter. This is a group of fellows that's board certified and fellowship trained, and they'd be happy to try to help you. This young lady, who also has lab coat and stethoscope, would love to try to help you, and she'd feel awful if you didn't get better, and she'd try her best to make it happy, but she's not board certified. That's my daughter. This is Dr. Seal, Dr. Wise, Dr. Kim, and myself. These are 2 board certified spine surgeons, fellowship trained spine surgeons, and then Dr. Kim and I are board certified fellowship trained pain management physicians. Pain management is more than just the prescription of pain pills. Pain medications may be appropriate and effective in certain situations or in many situations, but you really have to be careful. And so just reaching for a pain pill to manage someone's pain is usually, even though it may be with the right intention, may not be the best idea every time. You should usually try to limit the amount of pain pills. You have to be careful not to overprescribe. There is a cost to patients and the community. We see addiction in about 8 or 9% of patients. And addiction and pain medication problems with pain medications cause a big cost to the society and community. Not that I don't prescribe pain medications, that's my job, I'm a pain management doctor, but just want to highlight that's not the only thing we do, and that's not the only thing you should think of for your problem. The pain pills I'm talking about are the opioids. The opioids are all analogs of drugs like morphine, okay? They all bind the mu receptor. They all work in identical fashion at the end of the day. So sometimes you hear about the pain medications on TV and you think, oh, I wouldn't take that one. And patients say to me a lot, oh, no, I don't want to take that. And I said, well, you're already taking it. It's the same thing. I mean, they are all the same. If it's Percocet or OxyContin or morphine or fentanyl, whichever one gives you a bad vision in your head, the other one is the same. They all do the same thing. They just have different names. And some of them have bad reputation for a reason. But when we prescribe those medications, it's always with knowing the problem, okay? And they all do the same. And there's a spectrum of problems with pain medications, and that's why you have to be careful, and that's one of the reasons that physicians now choose to send it to a pain management specialist. They don't want to deal with the headache, with this spectrum of problem that comes with pain medicine that doesn't come with blood pressure medicine and diabetes medicine, okay? And that's substance abuse, addiction, diversion, and problems like that. Diversion is when people are losing it, it gets in the wrong hand, or selling it, or giving it to their friends and or their family and thinking it's a good thing, but it's not. It causes a problem. And there's a spectrum of problems that come with pain medication, and there's a spectrum of good results too. We have a lot of patients that have been on pain medication for years and years, and they do great. And this is the pain patient, and these patients we would call adherents. They listen to the doctor, they take the medicine and it works, and it's fine, and there's no problem. And that's most of the patients, the majority of the patient. Then you have patients that take the medicine and they're taking it more and more, or they need more and more for other reason, because of stress happens in the life or other issues come up, and the pain medicine can help to mask the stress and mask some of those psychological or social issues. And so those we consider a chemical coper. You have patients who just abuse it. They take more than they're supposed to. They lie and tell you that they lost it, or it got stolen, or their neighbor, or their kids, or whoever took it. We hear it all. And those are substance abuser. And these are pain patients. These patients have pain. I mean, you don't have just healthy patients lying to get medicine. These are patients that probably at some point need to have the pain medicine, but they still become abusers, intentionally or unintentionally, at no fault of their own and at no fault of the doctor necessarily, or maybe at fault of both. The doctor could prescribe it and not be paying attention to what he's doing and not seeing it, or the patient could lie. But whatever it happens, they're abusing it all of a sudden. And here is addiction. Addiction is when you're taking it recklessly and in a dangerous way and showing signs of obvious problem.